Hello, my name is Preeyanka Rao, and today I will be presenting on how we can leverage Medicare's Medication Therapy Management Program to reduce the use of potentially inappropriate medications. So, beginning in 2006, the Centers for Medicare and Medicaid introduced Medicare Part D, which is also known as the Medicare Prescription Drug Benefit. Part D required plan sponsors to offer programs called Medication Therapy Management Programs, or MTMs, for those eligible. You may ask, what are MTMs? Well, MTMs require pharmacists and other healthcare providers to work with patients to review their medications, and MTMs can be really beneficial as they can optimize therapeutic outcomes, reduce the risk of adverse events, increase medication adherence, and even reduce costs. Who is eligible for MTMs, though? Well, individuals can enroll if they have at least 2 to 3 chronic diseases, take 2 to 8 Part D drugs, and incur a cost of more than $46.96 annually. But we're going to be focusing specifically on potentially inappropriate medications. Potentially inappropriate medications are typically drugs to be avoided for use among the elderly because they have 1, a high risk of adverse reactions in this population, or 2, limited evidence of benefits in the presence of 1, safer alternatives, 2, equally effective alternatives, or 3, even more promising alternatives in terms of efficacy. But few studies have examined the impact of MTMs on PIM use. So that's what we did. We conducted a literature review, and using 4 search strings in PubMed, we extracted 218 studies. From this group, 68 duplicates were removed, leaving us with 150 studies to be screened. 116 of these studies were deemed irrelevant, oftentimes because they were located outside of the US or didn't use an explicitly Medicare population. Once we did that, we had 34 full-text studies that needed to be assessed for eligibility, of which 8 were to be included based off of our predetermined exclusion and inclusion criteria. Of the 8 studies that explicitly looked at PIM reduction, all studies indicated a reduction in PIM use. One excluded study that is notable, Scott 2010, even indicated that costs associated with MTMs were approximately $20,000 for 130 patients, indicating that even small gains in overall patient health can ensure the economic viability of MTM programs. While there may be a cost up front, it can avoid expensive costs associated with adverse events in this population. So what does this mean? First, that studies have found a reduction in PIM use post-MTMs, and 2, that MTMs may be a cost-effective strategy to reduce PIMs. We found some future directions for research that we believe should be considered. First, there are countries outside of the US, notably Scandinavian countries like Sweden, that have implemented similar MTM programs. Strategies in these international MTM programs should be researched to see if there are ways that we can improve our MTM programs. Secondly, we believe that provider perspectives on MTMs, such as PCPs, pharmacists, and nurse practitioners, as well as how we can effectively integrate MTMs into hospital and clinic workflow, should also be considered. Finally, few studies look at cost savings associated with MTM programs, which should also be explored further as well. Thank you for listening to my presentation. I'd like to give a special thanks to Dr. Anna Hung and the Duke-Margolis Summer Internship Program for the opportunity to conduct this research.